Our next speaker is Professor Mervat Abu Gabal from Ain Shams University. She will give us a presentation on monogenic vasculitis. So proceed, Professor Abu Gabal. We're listening.
صباح الخير. First of all, I want to thank my great professors. I want to thank our scientific committee and organizing committee for allowing me to participate in this great event. My topic today is monogenic vasculitis. Actually, I have few highlights regarding the differentiation between monogenic versus complex disorders in general, a few highlights regarding the meaning of precision medicine. Also, we will revise rapidly classification of necrotizing vasculitis. We will revise few forms of monogenic vasculitis. Finally, the message of my talk today will be summarized. At first, let's understand the difference between monogenic disorder and complex disorder in general. Monogenic disorder requires single gene variant to produce its phenotype, to produce its clinical manifestation. Usually, monogenic disorder has a strict Mendelian inheritance pattern, like sickle cell disease, cystic fibrosis, Duchenne muscle dystrophy. On the other hand, complex disorder requires multiple gene variants to produce its phenotype after interacting with environmental factors, like in cardiovascular disease, asthma, diabetes, and cancer susceptibility. So what? The answer to this question will be postponed till I talk about monogenic vasculitis. Now, what about history and evolution of vasculitis classification system? Rapidly, the first form of vasculitis discovered in 1860 and was termed as periarteritis nodosa. In 1952, Pierre-Lézig introduced the first structural classification of vasculitis based on vessel size. It included 5 entities of vasculitis. These entities were giant cell arteritis, polyarteritis nodosa, Serge-Strauss syndrome, Henoch-Schönlein-Purpura, and hypersensitivity vasculitis. In 1990, ACR released the classification criteria for 7 entities of vasculitis. These 7 entities included the previous Pierre-Lézig 5 entities, plus Takayasu arteritis and Wegener granulomatosis. In 1994, Chapel-Hill introduced definition and classification of vasculitis, which was revised in 2012. This Chapel-Hill classification included 10 entities of vasculitis, which were the ACR, the previous ACR classification of vasculitis, minus hypersensitivity vasculitis, but plus Kawasaki disease, microscopic polyangiitis, essential cryoglobulonemic vasculitis, cutaneous leukocytoclastic vasculitis. In the same Chapel-Hill classification, they introduced pathologic description for some forms of vasculitis when possible. Also, they incorporated serologic marker like ANCA into this classification. Since that time, 2012, no further classification of vasculitis till in 2017. In this review article, authors introduced classification for necrotizing vasculitis, but not released by ACR or EULAR. They stated that necrotizing vasculitis include Classic polyarthritis nodosa, the classic complex disease, also include the 3 ANCA-associated vasculitis, again include hepatitis B virus-associated vasculitis, and here this form of vasculitis is considered as secondary vasculitis to underlying probable etiology. And it was immune complex disease, or it's immune complex disease. Since that time, no further subdivision of polyarthritis nodosa for being with or without hepatitis B virus infection. There is classic primary polyarthritis nodosa and hepatitis B virus associated necrotizing vasculitis that resemble polyarthritis nodosa but is immune complex disease and is secondary vasculitis. In the same literature, they mentioned monogenic variant of vasculitis or monogenic disease to include SAVI-DADA2, familial Erythrean fever associated polyarthritis nodosa-like picture, and primary immune deficiency associated necrotizing vasculitis. Also, in the same literature, they mentioned the definition of monogenic vasculitis. They stated that severe mutations in single gene can result in similar phenotype to that seen in multifactorial complex disease. And here in the same literature, they give 2 examples. The first example is for polyarthritis nodosa as primary complex form of vasculitis with its monogenic variant, which mentioned before, SAVI-DADA2, familial Erythrean fever associated necrotizing vasculitis, and primary immune deficiency associated necrotizing vasculitis. They give another example regarding Behçet disease. Behçet disease is well known as a primary complex form of vasculitis, and there is monovariant or monogenic variant of Behçet disease that's haploinsufficiency A20. Single gene mutation in gene encoding for A20 protein result in Behçet-like disorder, which is monogenic variant. This means that, for example, as I said, in Behçet disease, this complex Behçet disease, which is associated with multiple gene variants, whether in HLA region, like HLA-P51, HLA-P57, HLA-A03, or outside HLA region, like interleukin-23 receptor, interleukin-12 receptor, P2 locus, interleukin-10 locus, and so on. On the other hand, there is monogenic variant of Behçet disease, which results from single gene mutation, gene encoding for A20 protein, which result in loss of function and deficiency of this protein, which augment signaling in nuclear factor kappa B pathway with increased production of pro-inflammatory cytokines dependent on this pathway. So what? There is primary complex vasculitic disorder and monogenic variant of this disorder. As you see, in monogenic variant of vasculitis here, there is specific or definite biologic pathway with its known or definite pro-inflammatory cytokines dependent on it. This biologic pathway with its dependent pro-inflammatory cytokines could be considered as new therapeutic target. And this monogenic variant of Behçet disease or of polyarthritis nodosa, as the previous example, may not respond to the standard therapy recommended for the primary complex disease, but require more targeted therapy. Hence the need for what's called precision medicine. From where the idea of precision medicine, it came from certain observation that a percentage of vasculitis patients don't adequately respond to standard treatment. Hence the need for precision medicine. Precision medicine is defined as designating medical care for each person with optimum efficiency in prevention and treatment by considering individual variability as regards genes, genetic profiling, environment, and lifestyle. This means that precision medicine enable translate bench-side knowledge to bedside and provide targeted treatment for the patient. Since that time, numerous genetic studies have been carried out to identify. Number one, Susceptibility loci and corresponding biologic pathway in vasculitis pathogenesis, which could be considered as new therapeutic target. Also, they try to identify genetic predictors of treatment response to improve use of existing drugs. Again, genetic profiling of patient provided by genetic studies carried out by different study groups like GWAS and ImmunoSheep provided important step forward in our understanding of vasculitis pathogenesis. And there are several GWAS results in different forms of vasculitis, like in Henoch-Schönlein-Purpura, Kawasaki disease, ANCA-associated vasculitis, Takayasu arthritis, and Behçet disease. Even more, in this literature, they provided timeline for the genetic findings for precision medicine in vasculitis, starting from 1975 by discovery of the genetic association between Behçet disease and HLA-P51 till 2017 with the discovery of the genetic association of giant cell arthritis. Even more, in the same literature, they provided table for different forms of vasculitis with their associated susceptibility loci outside HLA region and their corresponding chromosomal region. Even more, they provided another table for some forms of vasculitis with their gene-associated treatment response. Here is a time to tell certain fact, which is very important and well known by, especially by drug companies. The fact is that any drug with genetic support will have twice the opportunity to pass rapidly from phase 1 to approval compared to another drug without genetic support. Now, returning back to monogenic vasculitis. During all these genetic studies serving precision medicine, they discovered monogenic variant of vasculitis. Now, let's revise a few of them. The first one is DADA2 disease, deficiency of adenosine deaminase 2. Adenosine deaminase 2 is produced mainly by monocyte and macrophage of bone marrow and is essential for leukocyte growth and endothelial stability. When there is mutation in gene encoding for adenosine deaminase 2, this results in deficiency of adenosine deaminase 2, which in turn results in phenotype of necrotizing vasculitis that's similar to polyarthritis nodosa regarding its clinical manifestation and its histologic manifestation. But there are two points which are different from polyarthritis nodosa, the primary complex disease. These 2 points are: number one, DADA2 disease is autosomal recessive, so usually there is positive family history in patients with monogenic variant with DADA2 disease. Also, DADA2 disease affects cerebral blood vessels. Consequently, usually there is early stroke in patients with DADA2 disease. These 2 points considered as 2 red flags against presence of polyarthritis nodosa in patients with necrotizing vasculitis resemble polyarthritis nodosa. The recommended treatment for DADA2 disease, anti-tumor necrosis factor drugs, and in resistant cases, hematopoietic stem cell transplantation. Even more, in 2021, according to ACR guideline for management of polyarthritis nodosa, they stated that if in patients with clinical manifestations of DADA2 disease, they strongly recommend treatment with anti-TNF over glucocorticoids alone. The second form of monogenic vasculitis is necrotizing vasculitis associating familial Mediterranean fever. Discovery of this form or monogenic variant of vasculitis started by an observation. They observed that there is higher prevalence of polyarthritis nodosa in South Europe and Eastern Mediterranean area, whereas there is high rate of familial Mediterranean fever carrier. With genetic studies, they proved that mutation in familial Mediterranean fever gene MEFV, which encode for pyrene, result in uncontrolled production of interleukin-1, which in its turn result, in addition to serositis and periodic fever, it results in necrotizing vasculitis, resemble polyarthritis nodosa. But with perirenal hemorrhage, higher prevalence of perirenal hemorrhage and very high acute phase reactant. The recommended treatment for this form of monogenic vasculitis, glucocorticoids, and if there is familial Mediterranean fever, colchicine should be continued, and in resistant cases, interleukin-1 inhibitor. By the way, polyarthritis nodosa is not the only vasculitis in general that associate familial Mediterranean fever. In 1 to 7% of cases, there is Henoch-Lyme purpura. In other cases, leukocytoclastic vasculitis was reported. There are other case reports with familial Mediterranean fever, like coronary vasculitis, large vessel vasculitis, similar to Takayasu, cutaneous vasculitis with immune complex glomerulonephritis. The third form of monogenic variant of vasculitis was mentioned before. This is haploinsufficiency A20, single gene mutation in gene encoding for A20 protein, resulting in loss of function and augmentation of signaling through nuclear factor kappa P pathway with increased production of its dependent pro-inflammatory cytokines, resulting in PASIT-like disorder, similar to the primary complex PASIT disease. In review of 16 patients with haploinsufficiency A20, one of patients had central nervous system vasculitis, another one had retinal vasculitis, a third one had central nervous system vasculitis plus pulmonary artery impuli. In the next form of monogenic vasculitis, usually this occurs in children, SAVI, sting-associated vasculopathy of infancy. What's meant by sting? Stimulator of interferon gene protein. Here there is gain of function mutation of gene encoding for interferon. In gene encoding for sting, stimulator of interferon gene protein. This results in overproduction of interferon-1, which combine or bind its receptors, resulting in increased signaling through Janus activating kinase. This results in necrotizing vasculitis resemble polyarthritis nodosa, and in other patients it can result in picture of granulomatosis with polyangiitis with severe cutaneous vasculopathy, severe interstitial lung disease, and microthrombotic angiopathy. The recommended treatment for this patient is paristinab, which is Janus kinase inhibitor, because the mediating factor or the activating factor is Janus kinase activation. The last form today of monogenic variant of vasculitis are the primary immune deficiency associated necrotizing vasculitis that resemble polyarthritis nodosa. Again, single gene mutation in gene encoding for proteins which are involved in recombination in T and P cell can result in necrotizing vasculitis like resemble polyarthritis nodosa, and the recommended treatment for this form of vasculitis, in addition to glucocorticoids with or without steroid-sparing drugs, due to presence of immune deficiency, the underlying cause should be treated by either intravenous immunoglobulin or hematopoietic stem cell transplantation. Now we came to the message of this talk today, that genetic profiling of vasculitis patient help better understanding of vasculitis pathogenesis, help tailor treatment individually, which serves the goal of precision medicine. One of you will tell vasculitis group as rheumatologic disease are a rare group of disease. What about monogenic variant? They will be more rare. Yes, more rare. I will tell what about systemic lupus erythematosus, which is more common rheumatologic disorder. Since 2014, the concept of monogenic systemic lupus erythematosus became present, with many forms of monogenic variant of systemic lupus erythematosus which require more targeted therapy were discovered. The most important question now, when to suspect presence of monogenic variant of disease, especially in vasculitis, this must occur when there is atypical presentation regarding age or gender, when there is a strong family history, strict Mendelian inheritance or consanguinity in this family, when there is atypical manifestation like a picture of polyarthritis nodosa and necrotizing vasculitis, but with early stroke and positive family history, or with associating glomerulonephritis, which is is not characteristic of polyarthritis nodosa. Lastly, if the disorder is refractory to standard therapy, we must think of a monogenic variant of the disease which require more targeted therapy. Thank you.
Thanks, Professor Dr. Mervat, for this elegant presentation about genetics of vasculitis and the precise or personalized medicine. نستأذنك دقيقتين بس عشان دكتور راشد لقماني اونلاين معانا من لندن.
Just a question, just please.
أنا عايز أسأل سؤال.
أنا عايز أسأل
أولاً أنا عايز أشكرك الأول على هذه المحاضرة القيمة العميقة. أنا سعيد بيك يعني بصراحة، يعني دخلت في قصة ربنا اللي يعلم بها، بس أنا عايز أقول لك الإيجيسير نفسه عمل جواز ستاديز يعني بإشراف البروفيسور جعفر، وعملها مالتي سنتر هنا في مصر، وكانت على جواز في الروماتويد ارثرايتس، وبعد كده كملنا في السيستميك لوبس كان مع ألمانيا الموضوع ده، واتنشر في الهيومن جينيتكس كما أعتقد يعني.